I want to welcome everyone. I'm Don Liacano. I'm the program manager here at NAMI Davidson County. And in honor of tonight's education session, I will share that one of my diagnoses as a peer is OCD. So I'm looking forward to Dr. Amy Mariaskin's presentation tonight. As I mentioned to her before, we let people in the Zoom room that this is some information I'm sure myself and my family could have used a few decades ago, but I know it's going to be informative moving forward for myself and others. Both our lived experience people and the caregivers are here tonight. So welcome. This is our education session, Anxiety and OCD in Youth, presented by Dr. Amy Mariaskin, who is the founding director of the Nashville OCD and Anxiety Treatment Center. Couple housekeeping rules tonight. Please make sure to stay muted so the audio recording can be as clear as possible. If you want to ask questions during the presentation or after, if you can either unmute or put it in the chat, and our caregiver coordinator who's here, Eileen Wolf, and myself can ask the questions for you. So without further ado, I'm going to turn the presentation over to Dr. Amy Mariaskin.
All right, thank you, Don. Well, I'm excited to be here. It is between having just come back from a trip to Boston for a conference and the pollen in the air. My voice is kind of a little bit in and out at times, but I think I can hang through this presentation because this is absolutely probably my favorite thing to talk about, anxiety and OCD in youth. So I'm pretty casual. I think if people have questions, if you just want to kind of unmute, I can't see everybody's faces or anything like that. So if you want to unmute, or again, as Don said, if you put it in the chat and Eileen can read it out, I'm okay to take questions as we're going. But I am going to start by just talking a little bit about some of the basic, some of these different diagnoses, what they look like in kids, and then we'll get into it's mostly from kind of a parent perspective, what families can do to help out little ones and teens with OCD and anxiety. And then I'll get into briefly, I'll sort of touch on the evidence-based treatment that we have for OCD and anxiety in kids, which continues to grow in leaps and bounds. So a little bit about me. I'm a licensed clinical psychologist and owner and founding director of the Nashville OCD and Anxiety Treatment Center. We serve about ages 6 and up. I think right now our youngest is 6 and our oldest is 81 in terms of our clientele here. We're 18 different therapists. We have 2 locations, one in Brentwood, one in Mount Juliet. In addition to being a therapist and a clinic owner, I'm also the author of the book Thriving in Relationships When You Have OCD, because I'm really interested in OCD not only as an individual concern, but kind of how it affects important relationships and how people, caregivers and loved ones can kind of help alleviate symptoms. There's more information. So our Instagram is at OCD Nashville. We haven't been super active, but I do little mental health comics, and you'll see some of them in this presentation. I think maybe one of them, or OCDNashville.com. Okay, so I always want to start, let me see if I can move my face out of the way. Yeah, there we go. Okay, I always like to start by talking about, in order to determine what would count as like a disorder or a clinically significant concern, it's really important to think about what's common. And as we know, kids and teens, they do tend to have fears. In fact, anxiety is just sort of like a normal part of life, and it's an adaptive skill for people to have. So if you're looking at sort of 4 years to 8 years, you're going to see some separation anxiety, fear of animals and insects, fear of the dark, kind of supernatural beings, monsters, ghosts, things like that. Definitely weather, thunder and lightning, sleeping alone, and quote unquote bad people. And that's, of course, that's really subjective, but kids might hear about like, oh, well, you have to be careful when you go out because somebody could hurt you, or you have to be sort of vigilant. Now, again, as I'm talking through this, I want to be very clear that although PTSD or post-traumatic stress disorder, although kids who have experienced like a sort of what we'd call like a big T trauma, although that's certainly anxiety, that's not really going to be the focus here. So as I'm going through here, additionally, I mean, a kiddo who's afraid of thunder and lightning, who, you know, it's loud, it's scary, versus a kiddo who's been through, say, you know, the tornado that we had a few years back, we're going to treat that a little bit differently. And of course, you know, that's going to come into the calculus of, hey, is this really getting in the way? Is it something that, you know, would rise to being clinically significant or not? Again, 8 to 12 years, more kind of supernatural concepts, the dark. Bodily injury really comes online around this age. So kids getting really afraid of like, what if I get hurt? What if I go out in the sun too long? You know, what if I get sick? That kind of thing. You're seeing a lot more of that. So bodily injury or illness, heights, getting lost or trapped, etc. I won't sort of read them all. What's really interesting is that when you get to sort of like your tween and teen years, there is like the social anxiety really seems to ramp up. Now, again, it doesn't mean that, you know, people can have these fears at any age, but these are just the most common ones too. A lot of like social or evaluative situations. So being worried about getting teased or rejected by peers. And of course, if somebody has a marginalized identity, then that fear may also be founded in having some negative experiences. So again, there are some kind of nuances here in terms of, is this just kind of anxiety, it's out of nowhere, versus is it based on sort of life experiences? And for many people, it's kind of a combination of both. So again, more social things. So being embarrassed, dating, giving oral reports, so being in front of people, that kind of performance anxiety. So I bring this up not to say that like, okay, you know, if you have one of these fears and you're not in this age bracket, then it's for sure developmentally inappropriate, but just to get a sense that it would be quite different for, let's say like a 16-year-old who has a fear of the dark that's really preventing them from engaging in their life versus a 4-year-old, right? Whoops, here we go. So when do we worry about worry? Because everybody has worries, everybody has anxiety, and whether or not it's one of the more developmentally common themes or not, there are really 3 things that you want to consider. And one is the intensity. What is the degree of the stress? And I think about anxiety as being kind of like, you know, on a continuum from like, it's this purely internal experience. It's not really, you know, nobody else could tell, just sort of like a full-blown panic attack on this side. And in between, everybody's going to kind of manifest their anxiety a little bit differently. Some people will be easy criers. Some kids will kind of stomp and yell and it comes out sideways as anger. But thinking about the intensity is kind of one metric. And is it, again, rising to a level that would be above what we would expect is developmentally appropriate or typical? And then second, it's impairment. So is this stress or anxiety interfering with daily life? You know, again, a big difference between somebody who's, you know, I'm afraid of bugs, but, you know, I go to summer camp and it's okay. And I don't like them. And, you know, if I'm afraid one's going to bite me, like I might run away, versus I used to love going to summer camp. And then I started getting afraid of bugs. And now I'm not going anymore. I don't like going over to my friend's house because her trampoline is outside. And once I saw a bee on it. So what is the extent to which the anxiety is, you know, is keeping them from doing things that they otherwise want to do? And we think about, for kids, we think about impairment in 3 domains. So it's like family life, peers, and school are kind of the 3 big ones. And then finally, flexibility. Can the kiddo recover when the stressor is not present? So is it the sort of thing where it's like, okay, there's something I'm afraid of, you know, I'm afraid of storms, the storm passes, and I can kind of like come back and regulate and get back to baseline? Or is it something where it's like, are you sure? Is the storm going to come back? Are we going to be okay? When's the next storm coming? Can we check the radar, etc.? So it's that kind of like, flexibility is maybe not the best word here. It's kind of more like recovery, right? And again, we have different expectations for kids at different ages. Okay, So how prevalent is this? There was a large nationally representative study of over 10,000 kids, or I'm sorry, adolescents, and it showed that almost 32% of teenagers met criteria for an anxiety disorder, which sort of begs the question, if like a third of teens meet criteria for anxiety disorder, like, you know, when does it either cease to be a disorder, or what does it say about, you know, the stress that teens are under? I will say anxiety disorders are the most common, I believe the most common mental health concern with in adulthood. It's a little bit higher even. So it is, I think, like 33, 35%. But of adolescents with any anxiety disorder, an estimated 8.3 had severe impairment. So severe impairment means, you know, they're not attending school. We at our clinic, we see a lot of like kids who have school refusal, or they're, you know, leaving school early. There's a lot of family disruption. Families begin to sort of like change their routines or change their lives based on what the child's anxiety or OCD can handle. And we'll get into what is the difference between anxiety and OCD. We'll get into that. And then they tend to have fewer, apparently friendships. That should say friendships, but they have less of those. So, you know, it's again, when you think about it, three big domains, right? School, family, friends. And also I would say disruptions in friendships as well. If you look over time, people are always, you know, people often want to know, and I realize I'm giving you this information before I'm defining these things, but I'll get more into it. If you look at, say, panic disorder, which is one of the anxiety disorders, social phobia, which is another name for kind of like persistent social anxiety, and more generalized anxiety, they all have an increase, they all increase in likelihood over age. So especially with panic disorder, you're much more likely to see that in teens. We don't see like panic attacks in kids, and I'll get into what that usually looks like. But all of these ones, they're going to kind of increase over age. So your increase in likelihood over age. So you're much more likely for a 17-year-old to be diagnosed with any of these than, say, a 7-year-old. Among affected adolescents, 50% of anxiety disorders had their onset by age 6 for anxiety disorders. Now that's interesting. So about half of them are going to show this like early childhood manifestation, and they might not get diagnosed at that time, but you might see things like you know, like slow to warm up socially, or what we call behavioral inhibition, which is this tendency for some kids, if presented with a new task, some of them are like, yeah, like they're right in there. They're, you know, do not pass go. They're just in it. And then others are going to kind of like, well, wait, I need to, you know, I need to assess things. I'm going to be a little bit more cautious. Having an anxiety disorder also confers a risk for developing other types of anxiety disorders or psychiatric disorders. So fully about 75% of individuals with anxiety disorder also meet the criteria for another psychiatric disorder. That could be a mood disorder. That could be like a PTSD. It could be autism. And so that's all psychiatric disorders, but half of people with anxiety disorder actually meet criteria for another anxiety disorder. And this is in adults. So this is kind of over the course of one's life. So, you know, generalized anxiety and social anxiety, for example, might come together, or things like that. Or you might have a phobia early on and then have social anxiety later. Okay, other possible outcomes include panic attacks, suicidal ideation or gestures, and substance use. Sorry, these are kind of older slides. Okay, so I'd like to get in right now to some of the different diagnoses. And please, like I said, if you have any questions or anything like that, feel free to kind of jump in. But I'm not going to get into every single anxiety disorder that's listed in the DSM, but I am going to highlight the 5 that are here. Generalized anxiety, or sometimes we'll just call it GAD, social anxiety, panic disorder, phobias, and separation anxiety. At the bottom here, so also illness anxiety disorder, which is technically not in the anxiety disorders category. OCD and PTSD, they're kind of not in that same part of the DSM, but they still count as anxiety-based disorders. I will be talking as well about OCD. And I lump illness, anxiety, and OCD in together. So when I talk about OCD, I can bring up some illness, anxiety examples as well. They have a very similar cycle. Okay. So GAD, this is really like, these are the kiddos who are just, they're the little worry warts. They're the ones who, you know, if there's something to worry about, I'm going to find it and I'm going to worry about it. So there tend to be multiple areas of worry, as opposed to like a phobia, which is usually about, you know, one thing or one situation. Generalized anxiety disorder can be like, well, I'm afraid about, like, did I do well on this test? But I'm also afraid because, you know, I saw this thing on the news that said, you know, that somebody was shot, and could I get shot? And it's just kind of like whatever's out, it's very opportunistic, right? Generalized anxiety as well. I heard this one scary thing. Could that be me? So it's like a persistent what if. There are also associated symptoms. They're physical in nature. So we'll often see like kids are kind of restless. They're moving around a lot. They're keyed up. They might be on edge. Now, again, as I'm talking, you might be thinking, well, like, okay, well, ADHD, you see a lot of that. And okay, there's a lot of what ifs. Well, OCD, you see a lot of that. Yes. I mean, I think there's a lot of overlap here as well. These kids tend to be easily fatigued. They oftentimes also have difficulty sleeping, which leads to more fatigue. They might be the kiddos who have a hard time falling asleep, or, you know, wake up in the middle of the night. These are kids where, like, you'll see there's little bitties with like muscle tension, irritability, sometimes difficulty concentrating, or their mind will go blank. So again, sometimes when kids come in with these symptoms, I'm really thinking about, as a therapist, I'm thinking about, okay, is this anxiety? Is this something like some sort of attention deficit process going on? And usually I want to treat the anxiety. And when that's reduced, if we still have some of these other things like difficulty concentrating, then we can consider that maybe, you know, there's an attention concern as well. So an estimated 5.7% of US adults experience generalized anxiety disorder at some time in their lives. So it's a pretty big one. At our clinic, it is the second most common disorder that we work with after OCD. All right. Social anxiety, also known as social phobia. And this is exactly what you would think. You know, it's fear or anxiety about one or more social situation in which the person is exposed to possible scrutiny by others. So somebody with social anxiety, you know, might have a hard time in this situation where I'm giving a presentation to a bunch of people, right? Also, you know, so definitely performances and things like that, but also just kind of general social interactions, right? Difficulty. What if I say the wrong thing? What if I embarrass myself? Fear of embarrassment or humiliation tends to be like a common and persistent thought pattern that people with social anxiety have. Yeah, so I guess that's the fear of acting in a way that will reveal anxiety symptoms that will be negatively evaluated by others. Yeah, so sometimes it's very circular. It's right, like, well, I'm anxious, I have social anxiety, and now I'm worried people will see that I'm socially anxious, right? So it kind of, that's one of the patterns. This is about 7% of the general population, and it is more common in women and people assigned female at birth. So we see a female preponderance of almost 2 to 1 with social anxiety. Again, that doesn't mean that it can't happen in other genders. It's just that, like, that's how it tends to shake out. And we could talk about, you know, socialization or what have you, or some causes for that. Okay, so let's see. So one study, and this is a little bit older, found that half of social anxiety patients had onset by age 13 and 90% by age 23. It is very rare that I will work with an adult who says, like, you know, I just had an onset of social anxiety in my 30s and my 40s. It tends to be something that if it's going to happen, it's going to happen around the teen years and then by early 20s almost for sure. And this can cause significant disability in terms of, cutting people off from being able to, just being able to do the things that they want to do, be that employment or otherwise. And it also confers an increased risk for depressive disorder. So, being socially anxious, it tends to kind of go along with having really self-critical thoughts, which makes sense that that would be related to depression. Any questions so far about these two? Okay. All right, so I'll talk a little bit now about panic disorder. And to talk about panic disorders, first you have to talk about panic attacks. And panic attacks, which are very, very common. So I'm sure there are people, here listening to this who have had them. These are kind of physiological symptoms, such as the ones that I have listed below. And people can have panic manifest in different ways. So these are just some examples, but hyperventilating, trembling, dizziness, heart palpitations, chest pains, sweating. Sometimes some people get it real like in the GI region. So, nausea, abdominal discomfort, diarrhea, urgency to avoid one's bowels. And then numbness, tingling, and then also derealization or depersonalization. And derealization is that idea that like I sort of look out in the world and it doesn't quite seem right, or I feel like I'm in a dream. And that can be really scary, which in turn can then increase panic symptoms. Depersonalization is this idea that like I'm not real or I'm not really in my body. Why does this happen? Well, this is our autonomic nervous system. So for people, when they get really nervous, it's a kind of fight or flight goes into effect. And for some people, you'll have these physiological symptoms. To actually have that be a panic disorder diagnosis, you also have to have fear of having so if you have a panic attack, that doesn't give you panic disorder. Many, many people have them. But if you have panic attacks and then your fear of having subsequent panic attacks leads to avoidance or impairment. So it's really, really common for people to avoid driving because they're worried about having a panic attack in the car, because it's a pretty inconvenient place to have a panic attack. Then that would sort of elevate it to the status of panic disorder. And in kids, this is way more common in teens than in younger kids. That being said, I've worked with kiddos as young as 8 who have had panic attacks. And really providing them with education about like, wow, it feels so dangerous and it feels so scary, but it's actually not dangerous. That's kind of part of it. And then we do something I'll get into a little bit later with exposure therapy. The exposure therapy for panic attacks involves people doing things that create some of those same panic sensations. So for like having, feeling like you have to hyperventilate, we might have people breathe through a little coffee straw. Dizziness, I've got my spinny chair, we can do that. And it really develops this new relationship with like, hey, I can have uncomfortable sensations and they're not scary, if that makes sense. That kind of is part of the treatment for panic disorder. Okay, phobias. I think everybody probably has a pretty good sense of what a phobia is or what that entails, but it's, persistent irrational fear about a specific situation or object. And kids may not know it's irrational, right? Because kids are, all they know is it's really scary and I want to get away. But these objects or situations are actively avoided or endured with intense distress, causing significant impairment. So, as I mentioned before, I used the bug example, but let's go with another animal one, a dog phobia. If somebody has a dog phobia and you don't have a dog and you're not around dogs, or somebody has a dog fear, it's probably not going to get elevated to the point of a phobia where it's significantly impairing. But let's say you have a kiddo who's also, has some medical concerns, has to go get blood drawn a lot, and they have a blood injection injury phobia, which is one of the kind of subtypes. Well, then that might rise to the point where, hey, this is phobic. This is really causing them at least intense distress, or they're trying to avoid it. We do tend to see these subtypes, and there's some cool research looking at how, most phobias tend to have some sort of tend to be tied to things that would have been evolutionarily adaptive at one point. So if you think about it, it's, we don't really have phobias about electrical outlets or things like that, even though, you could get harmed by one, or there could be an electrical fire or something. It tends to be this animal, natural environment, those kinds of things. Vomiting is an incredibly common phobia. I talk about it all the time, in part because this was my first big symptom when I was a kid. I'm somebody who's been diagnosed with OCD and depression. Haven't really had impairing symptoms of either in many years, but a fear of vomit and vomiting was kind of part of my OCD. And I was just completely embarrassed. I was like, well, these kids are, it's like third grade. This kid's vomiting over here. They're throwing sawdust on some more vomit. Everybody seems chill. And I'm over here rocking back and forth. So I never told anyone, but it is very common. And fear of vomiting is an interesting one because it can be social anxiety. Like, what if I throw up and, everybody sees me and it's so embarrassing? Fear of vomiting can also be related to OCD or contamination, or what if I get something nasty in me and I have to get it out, or I'm exposed to somebody else's vomit, or it can be a phobia. So it's a really, really interesting one. But yeah, that's phobias. Okay. Separation anxiety. So this is developmentally inappropriate and excessive fear or anxiety concerning separation, and then at least 3 of the things below. So we have physical symptoms, we have distress when separated or anticipating separation, worry about losing loved ones, to death, or that they'll get lost. Kids have all kinds of worries about things like that. Worries about something bad happening. We see a lot of fears about sleepovers. So it's not just for some kids, it's leaving home. For some kids, it's very specific to sleeping over. What if something bad happens? What if I can't go to sleep? Etc. And separation anxiety tends to be, of all these anxiety disorders, this is the one that we tend to see in the littles the most. Okay. And I have more slides about OCD because it's my favorite. And also I think that it's perhaps not as well known or understood as some of these other concerns. So OCD is marked by obsessions and compulsions. So obsessions are intrusive and upsetting, recurrent and persistent thoughts, images, or impulses. So, the classic one could be, oh, my hands are dirty, I have to go wash my hands. On the next slide, I'm going to talk about some other kinds of obsessions. It could also be, what if I harmed someone? Oh, what if I was walking past my friend Tommy's desk and and my pencil was out? What if I stabbed him? I should go back and check. Is he okay? Is he bleeding? So those are obsessions. They're unwanted. They're repetitive. And on the next slide, I'll have some more content. And then compulsions are these kind of repetitive behaviors or mental acts that people do to alleviate the anxiety. So this could be like washing is a really common one. I'm going to wash my hands again. I'm going to wash my clothes. I'm going to wash, things in my room. Or checking. I'm going to check to make sure I didn't hurt anyone. I'm going to check to make sure I didn't have any mistakes on my schoolwork. Reassurance seeking is a huge one. Did somebody have a question?
I've muted the person. I don't
Okay. Thanks. All right. And so technically, to get a diagnosis, a kiddo has to have at least one of these obsessions or compulsions and cause significant impairment or distress. People have both. I think part of what is difficult is that there's, Madeline, I'll get to you in a moment, but I think what's difficult is that for a long time, people had talked about pure O or purely obsessive. It's just, oh, I'm just having the worries. And what we've come to realize is that people are really doing compulsions in their heads. That might be self-reassurance. It might be kind of reminding yourself, going back, okay, I didn't stab Tommy. Okay, I'm good. Okay, I didn't stab Tommy. Well, that doesn't look like compulsions. It's all happening internally. Yeah, Madeline.
Okay, so thank you so much, Dr. Mariaskin. So the obsession part of what you were talking about of the what ifs, that sounds a lot similar to generalized anxiety disorder. So how do you distinguish an adolescent or even a teenager that's experiencing these what ifs, these obsessions, and then to say, okay, is this OCD or is this GAD?
Such a good question. And I'm hoping that this next slide will help, like, get there a little bit more. I'm basically with the what ifs, I'm looking for, are they falling, number one, are they falling into what we would call like an OC typical category? Obsessions tend to be a little bit less, pedestrian is not the right word, a little bit less kind of like your everyday fears, right? So they're a little bit less of, in OCD, you would see less of like, well, I'm afraid it's gonna, like my baseball game's gonna get rained out or something like that. I'm afraid that I didn't do well on that test. And they're a little bit more, either there's a lot of them, they can be taboo, or they can be, or they're just sort of more extreme. So, and sometimes they have this component of magical thinking. So if we go back to the, well, I don't want my baseball game to get rained out. And if I tie my shoes just right, then I can prevent it from happening. So it's both like the content of the obsessions as well as the presence of compulsions. So here are just some common obsessions. So we talked about contamination, the harm and aggression. This can be really scary for parents and loved ones because it can sound like, please take that, mommy, put those knives away, because what if I pick one up and I stab myself? I don't want to, but what if I do? I don't want to, but I know sometimes people can hurt themselves, right? So it's this, it's not a, it's what we call ego dystonic, meaning you don't want to do it. It's a fear of doing it. But just to say that it can be harm to oneself, it can be harm toward others or aggression toward others. Sexual obsessions as well. And a lot of times parents will say, oh, does that mean that they were exposed to something that is inappropriate? And not necessarily. I mean, OCD can really go for certain things. I worked with a 5-year-old at one point who had this intrusive obsession of, what if I lift up people's shirts while I'm out, we're walking around. What if I try, basically, what if I try to breastfeed from like a stranger? She's like, and I know that's not right. And I know that's a private potty part. And so those would be kind of just unwanted, again, sexual thoughts, images, impulses. Scrupulosity is religious symptoms, or I always think about it like perfectionism about one's faith. So I tell people of faith backgrounds who have OCD, hey, I want for you to, practice your faith. I just don't want all those extra rules on top of it, right? Saying, you have to pray just so. If you get one word wrong, you have to start over. Let's really, that would be the part that's compulsive. I don't know, are any of these questions in the chat? Oh, get a copy. Okay. You're welcome. You're welcome, Madeline. Okay. Yeah, so common compulsions, we have washing, checking, praying. And again, not to say that prayer is inherently compulsive, but really once OCD gets its little fingers in there, it really can be. Repeating, I have to repeat something over and over again until it feels right. Up and down from a chair, in and out of a doorway. Counting, I have to count my steps. I have to end on an even step. I have to count the tiles in the ceiling every time I go in somewhere. And that could be tied to, or else something bad is going to happen. Or it could just be tied to this last obsession category, which is just right. It just has to feel right. And there's no or else. It's just, oh, it's like I have an itch and I need to scratch it. Arranging, hoarding, which is a separate concern, but in kiddos, I'll often see hoarding. It's a really common, like, it's not true hoarding, but collecting. And it's really sweet. Kids will be like, oh, I have a rock collection. And then the parents will be like, it's like our entire living room is rocks. Can you help? But, so these are some common symptoms. Any questions about those? I love sharing this slide. So this is one of the, like I said, I make these little comics, and this is one that I made for our Instagram. I am I want to spread knowledge that OCD is a disorder. It's not a personality. So a lot of times you'll see people using OCD as shorthand, like, oh, I'm so OCD, you know, I'd never be late. And, you know, if you know one person with OCD, you know one person with OCD. There's a lot of variability. So people can be organized, messy, tender, tough, calculated, spontaneous. So I think sometimes, especially if parents are like, well, but have you seen my teenager's room? It's definitely not OCD. I'm like, well, it might not be ordering, arranging, and cleaning, but it could be something else. So, okay. OCD prevalence rates vary between about 1% and 3%. And it's really interesting. OCD is one of those disorders. If you look cross-culturally, cross-nationally, there are very consistent rates. So it's not as much culture bound as, say, some other disorders might be. Although I will say the content, again, can kind of glom onto whatever is important in a culture. Kids are closer to about 1%. Adults closer to about, so 2% once you get to adulthood. And about half of people with OCD experience their onset in childhood. So that means, yeah, lots of kiddos out there. 21% have an onset before age 10. And when you look at sort of the mean onset for kids and teens, it's a little bit earlier for boys than it is for girls. That being said, I was, I think 5 or 6 when my symptoms started. So there's variability there. If you do have early onset OCD, so if you're somebody who had OCD symptoms starting in childhood, or if you have somebody in your family who has that, that has a higher sort of genetic loading. So you're more likely to sort of like pass that on or have it run in the family. So to illustrate that, 20% of the first degree relatives of somebody with early onset OCD also had OCD. But if you look at people who had adult onset OCD, that goes down to 12%. I know that's a little bit, I think I wrote it out kind of weird, but I hope that's clear. So yeah, it is. And by first degree relatives, nuclear family.
And I have a question or a comment, a little bit of both. I am someone who has lived with OCD for at least 4 decades, probably 3 of them aware of what it was. When I was a stay-at-home parent and my OCD was flaring during a very stressful time, those in my life felt that I could be teaching or modeling so that my offspring could have OCD. By me having OCD, can it be passed on through learning from the parent in the sense of, if I check the blinds, etc., is that teaching the child that's a normal behavior?
It's such a good question. And it's one that we can't so I would say no. I would say
that's
no.
what I said multiple times.
Good. Yeah, because I mean, there's no ethical experiment in which you could kind of be like, okay, well, we're going to take one sample, with the way that I look at it is, in particular, more so than many other disorders. I mean, not all of them, not say bipolar, I know has a very high genetic loading, and bipolar disorder and schizophrenia. But I think there's some kind of like vulnerability. And if somebody has that pre-existing vulnerability, and then there are certain environmental factors, sure, it could bring out similar kind of symptoms, but I would never say, I don't think it's something that can just be like learned.
Unfortunately, the offspring did inherit it, but a different form of it. So as we talked before this program, it takes many forms, and I have been approached many times. I wish I had OCD so I can have a clean house. It doesn't work that way. It means that corner over there hasn't been cleaned in three months because I'm afraid to move the chair, because if I start moving the chair, I'm going to spend another hour and a half getting the chair just right.
Oh, right. Yeah. Yeah. Well, I like this diagram here sort of talks about, and we could fill in any of the anxiety-based concerns, including OCD. OCD looks a little bit different, but what is the anxiety cycle? And as loved ones or people who, if you're interacting with youth with OCD and anxiety, really the cycle is perpetuated here by there's some kind of a situation. And here we have a kiddo with the fear of dogs. There's some kind of like appraisal of the situation, that dog is going to bite me, or maybe I've been bitten by a dog before, or hey, my friend, down the street got bitten. There's fear, there's avoidance, and then by avoiding this situation, I'm not going to be around dogs. It becomes sort of reinforced with the idea of I'm safe because I'm staying away from a dog. Nothing bad is happening because I'm avoiding. Now, what's different in OCD is sometimes that bottom thing, instead of just avoiding, sometimes the thing that kind of reinforces is you're doing a compulsion. Okay, I wash my hands and I feel better. Okay, well, next time I'm going to wash my hands again. But there's always this kind of cycle. And as I'm a cognitive behavioral therapist, I really want to focus in on what are those thoughts that are happening and what are the avoidance behaviors or compulsive behaviors, because that's going to keep it going. Okay. So this is from some slides that I did a talk for parents, and just sort of talking about when you have a child with anxiety. Well, maybe I'll do this slide first, and then I'll come back. This has been around, I think, forever, approximately. But this is a kind of parenting grid of sort of different parenting styles. And so if you look on the top, you have supportive versus unsupportive, and supportive meaning parents who are accepting, child-centered, and unsupportive, rejecting, parent-centered, my way or the highway. And then on the left side here, you have the two, the dimensions of demanding or undemanding. So how much you sort of expect of a child. And this very first one, where it's 2 in the green here with authoritative parenting, is really thought to be for most kids. And again, there's goodness of fit, and it depends on, a lot of things, but this is basically going to be where kids thrive, right? It's a reciprocal relationship. There's a lot of responsiveness from a parent and good communication. The ones that I'm going to flip back to the other slide would be kind of in this second, would be in this permissive parenting one down here. So the bottom left, and then the top right, authoritarian. And these are the two most common kind of like parenting, unhelpful parenting styles that I see. I actually don't see a lot of the like rejecting, uninvolved parents, which obviously would also not be helpful to anyone, anxiety or not. But I like to call this kind of like, it's the drill sergeant and the coddler. So the drill sergeant is, suck it up, do it anyway, pull yourself up by your bootstraps. That's irrational. I don't know why you're anxious about this. And there's a lot of like losing patience, and it's really invalidating, because some kids, I mean, even young kids, some of them know it's not rational. It doesn't make it go away. You can have, say, OCD and know that, I know it's irrational that I have to take 3 sips at a time of my water, or else, I'm going to have a heart attack. But just in case, I'm going to do it because it's really scary. So saying like, that's not real. A lot of times kids are like, I know. And so really like that validation is crucial to say, hey, this is real for you. Or, a child who's an athlete, let's say a teenager who's an athlete, and they're really afraid, what if everybody judges me when I get out there and I'm playing volleyball and I'm terrible, and and the parent says, come on, every single time you've been like the MVP 3 out of 4 times, like get out there. I mean, it's okay to say, hey, you actually do really well. But to say first, I know you're really anxious, boy, your mind is putting you through it right now. And I know how brave you are. And I know you're going to do your best. There's just, that validation is important. Now, the coddler, we're going to talk about a lot more. This is a parent or a loved one jumping in to provide comfort. which again, they have the validation that the drill sergeant lacks, they have in spades, but they don't have, they're sort of limiting their expectations of what the kiddo can do. So it's allowing kids to avoid any difficulty, rescuing the child from anxiety, limiting independence by doing things for the kid. So, you know, oh, and this is really common, like, oh, you know, you're really anxious about that, or I know we signed you up for 6 weeks of this camp, but you really don't like it after week 1, you're kind of nervous, you don't have to go. And again, I know on the surface that seems like, oh, is that the kind thing to do? Well, over time, it's really going to limit their independence, their self-confidence, their self-efficacy, like I can get out there and do things. Yeah, so that would be kind of this permissive parenting. You're not really expecting very much of them, but you're very supportive, whereas the other one is just, you know, it's my way or the highway.
Would the coddler, in essence, be enabling the OCD behavior?
Yeah, I think that's a good way to put it. It is enabling the OCD behavior, and it's almost like validating the OCD behavior or the anxiety behavior. Like, you know, hey, like let's say a kid with weather anxiety, can we look at the radar? Can we look at the radar again and again and again? Can we look at it? Can we look at it? If you're like, sure, keep looking at it, you're implicitly saying like, we need to look at it or else. Instead of saying, you know what? The grown-ups have looked at it. We think it's okay. We're kind of in the safe place. Hey, if there's like a tornado warning or something, the siren goes off, then we'll go to our safe place, but we're going to stay here. So it kind of is enabling. We call it accommodating.
But when did, an example, and I'll just a personal example. I asked someone to see, is that picture straight? I asked them once, is that enabling my OCD? The one time? Or
Well,
if I continue to ask and say, will you check again? Can we check in this light? Can we check with a magnifying glass? Can we measure it? All those things.
Right.
When does it become enabling?
It's a good question because you could, I mean, I could see it either way. Definitely the second way, if it's like, I'm not accepting an answer.
Yeah.
But if it's a sort of thing where, and I guess too, part of it is like, well, what if they said, no, it's not straight? Would you have to go and change it? You know what I mean? Because it's part of it, like somebody saying, you know, maybe not, it's straight enough. Like I'm annoying because I'm a therapist. So I'm always like, maybe not. And people are like, oh, I just want an answer. Like, but if I tell you one, then I'm sort of saying it's important. Yeah. Madeline, yeah, you're welcome. Did you?
Yeah, sorry. So my question was very similar to what that gentleman just spoke about. But so I know in some of the compulsions, yeah, is it like a thought that needs to be spoken out and told to somebody? And sometimes that parent may feel like the enabler, but isn't that one of the maybe intrusive thoughts or compulsions that an individual with OCD does experience? So yeah, I guess my question really was like, when is it considered enabling when that is something that an individual with OCD is experiencing, but also you want to be encouraging. So that balance.
Yeah. Do you mean like somebody who has almost a compulsion to like not confess, but to verbalize everything? Is that what you're saying?
Yeah. Yeah.
Yeah, it's interesting. I think if somebody's aware of that and they have OCD and like, let's say, I don't know, with younger kids, it's a little bit harder. And they say, I really want to tell you this. I really want to tell you this. I mean, even little kids though, when I work with them for a while, I'll be like, huh. And a lot of times kids, name their OCD. And one of the cutest names right now is that I'm working with a kiddo who named her OCD Sneaky Brain. And so I'll say like, do you really want to say that? Or does Sneaky Brain really want to say that? And sometimes she's like, she can kind of tell at this point. I think you might also be getting at, so the enabling would come in the like, yeah, of, you know, yes, tell me, I guess with reassurance seeking, which we'll get into, I see a lot more where kids are like, can you tell me for sure? I know I already asked this, but can you tell me? Yeah, I would say that is accommodation. And we can talk about some really kind ways to say, you know what, oh, I know how scared you are and you want me to answer that again. And guess what? You're actually even a little bit frustrated. And I know that just like kind of feeds sneaky brain and makes them bigger. So what about if I don't answer that? And then if you're still feeling that way in 10 minutes, we can do it. I can answer that.
No,
Does
that's
that-
exactly what I'm talking about. Yeah.
Good.
Awesome. Thanks.
Of course. All right. So what can parents do? So encourage your child to label anxiety, if you are a parent or, your loved one, to label anxiety. So a lot of times, especially with little kids, they're just like, oh, my head hurts or my tummy aches. Like they don't know that it's anxiety. So I'm teaching them kind of like, oh, it sounds like you're kind of scared. Are you scared? Are you anxious? Or whatever word they like. Are you worried? And then I often use a scale to rate anxiety for younger kids. Instead of doing like a 0 to 10, you can do a stoplight system. So like green is like, I'm feeling pretty good. Yellow is like, I'm a little nervous. And red is like, no, thank you. And that helps too. It's just helping kids to realize like a lot of times kids sort of lack the ability to, they're just like, I'm scared or I'm not, I'm scared or I'm not. And so saying like, well, but can you be a little scared and still do something can be kind of a game changer. I will also say for autistic kids, sometimes the scales can be a little bit difficult because again, it can feel very kind of all or nothing. That being said, sometimes just using like fewer numbers on the scale or things like that, or sort of appealing to if there's a special area of interest where I had one kid who was his anxiety was sort of, I can't remember what it was, but it was from some role-playing game. And it was like these different characters based on like how big and mean the characters were. Okay, so you can do that. Just kind of ask them, what do you, is that anxiety? Where is your anxiety? Is it like a 9, a 10, a 3? And then developing a plan to progressively confront anxiety-provoking situations. So this is exposure therapy. And I have to tell you, if you're recoiling by hearing that, many people do, I think exposure therapy has a bad rap. I'm here to tell you, if you are afraid of spiders and you come for exposure therapy for arachnophobia, I do not start by throwing a tarantula in your face. I might start by saying the word tarantula. It depends. We sort of meet you like where you are. I do have in the back in our, in an office, I don't have a tarantula, but I have a tarantula molt. So we keep things that are going to be, anxiety provoking, and doing it gradually and progressively. And in particular, doing it to help kids get back to the things that they want to be doing, right? Like I have social anxiety, but I really, I have a violin solo and I really want to do that. Okay, well, why don't you come in? We'll start, you'll play in front of me and then maybe you'll play in front of other people here in the clinic. I'm sorry, I'm saying it as if you're a therapist, but can you play with mom and dad like outside of the door? Okay, now what about with us inside? Can you play and make a little mistake in front of people? Because guess what? Mistakes happen. We can also kind of get at that perfectionism. Challenging unrealistic and unhelpful thoughts. Like I said, perfectionism is huge. The more that I can have kiddos practice being wonderful, vibrant, messy humans who make mistakes, the better. And having fun with it. So you don't have to be perfect. You don't have to know things just right. You don't have to, playing around with that kind of stuff. Modeling positive responses to anxiety. So, for me, what that means is family members giving themselves permission to say if they're scared. I mean, as a therapist, I know it keeps going back to storms, but I can't remember when this was. I think it was sometime last year. I was doing a session from home, a virtual session. And during the session, and my client was in Williamson County and I was in Davidson County, I got the little alert that where it was like my neighborhood came up and it was like, if you're in Bellevue, take cover. So I had the laptop and I said, you know what, I'll feel a little bit more safe if I go into the bathroom. So, and I bring my dog in. So I'm in my tiny little internal bathroom with my dog. She gets to meet my dog. That was kind of fun. And I was like, yeah, I'm a little bit nervous, but I'm doing everything I can to stay safe. So that's what I can do. And I think that was really you know, it's that kind of thing. So it's not only like modeling, like, I'm brave, I do all the things, but like, I'm scared and I'm doing all the things. That's even more powerful. Okay, let me see where I am on time. Okay, and then reducing accommodation as well. So what is
I have
accommodation?
a quick, you may cover this later, and if you do, just say that you will. But I'm curious I've experienced this more as an adult, but I'm sure children who are in school and display signs of OCD in front of classmates do take a little bit of bullying and being made fun of. Is there a strategy that you work with the kids about how to handle that? Because again, I've been laughed at by adults about some of my OCD behaviors, especially when I was honest about that bothers you. It becomes a joke, and I'm like, I can joke about it myself, but how do you help kids deal with that type of stigma?
Yeah, oh, that's such a good question. I will say it depends on the kid, because I've definitely had some kids, and I've yeah, with OCD, and then I also do work with tic disorders, and I've had some kids with tics who get bullied or made fun of, and then they've become these like awesome little advocates who are out there being like, I'm doing a school presentation on Tourette's. And I'm like, okay. So if there are kids who kind of have more of that slant to things, then I will have them, number one, if the teachers aren't aware of it, you know, or the school's not aware, I'll make sure that, you know, we can get a meeting with parents and school, et cetera. You know, some kids are still going to tease with education. But I do think that education, if teachers can provide that, you know, if the child doesn't want to do it, which is completely understandable. But I'll give kids strategies to say things like, you know, hey, I have something called OCD, or I have something called, you know, panic disorder. And sometimes, you know, it's just like any other illness. Like, you know how so-and-so uses an inhaler when she has an asthma attack. So there's some of those kinds of things. I also, you know, just from a sort of behavioral reinforcement perspective, and I hate this because it feels insufficient to me, but I also talk to them about, you know, having the confidence to know that, like, you know, these people don't understand, and so to be as like non-reactive as possible, because I think sometimes, like, if it gets escalated, then you get teased more. So those are some of the kinds of things. But yeah, I always just want to, like, let me see these children. I want to tell them everything about OCD.
I'm the same way, but thank you for answering that question.
Of course. So what is symptom accommodation? So these are any actions by others that kind of acquiesce to the child's demand. So allowing a kid to miss activities to minimize discomfort, participating in symptoms. So sleeping in a kiddo's room, helping to quote unquote check for monsters, speaking for the child. If this is, let's say, a 15-year-old with social anxiety, you know, and you're at a restaurant and you end up ordering for them because they're too worried. Now, I know a lot of these, like sleeping in a kid's room, like that seems really sweet, right? And it is, it can be. If it's something that has to happen sort of every night, then I would be looking for, okay, we really want you, hey, you want to be able to sleep alone, you even want to be able to go to sleepovers. Let's kind of like gradually and progressively remove this. And I use a lot of like incentives, rewards, things like that. Providing reassurance. I have a whole other slide on reassurance because yes, very, very common. So answering questions repeatedly, and this isn't just questions that are seeking information. It's truly like, I need to get that just right feeling. Decreasing a kid's responsibility. So, you know, I'm not going to discipline them. I know they have OCD. They were really stressed out when they wrote all over the wall. And I say, like, writing on the wall isn't usually a compulsion. Or, you know, like hitting somebody isn't usually a compulsion. You can say, I know you have OCD, and yeah, you can't control that you have these really big emotions, but you can control like what you do with them. Assisting or completing tasks for the kiddo. So providing extra assistance with homework, chores, etc. I've even seen like some kids who have writing and rewriting, and it takes them forever to get their homework done. I've seen parents who are like, well, I just do their homework. You know, they give some input. And again, all of this is very well intentioned. I'm a therapist and I'm still accommodating people when they come in because it's a part of meeting people where they are. And then you want to sort of gradually reduce it. And I know when we talk about, well, let me give some more examples and then I'll get into the next part. So some examples of accommodation could be allowing socially anxious kids not to do group work, or kids who have illness, anxiety, or worries about contamination. Providing alternative settings for tasks. I guess that would be like in school. And I guess I want to contrast this with appropriate accommodations in school, like taking a kid out of a classroom to do a test if they have learning differences or things like that, and they need a distraction-free environment. That's different because that's not something that that's not reinforcing the learning difference. It's just helping them to work to their potential, as opposed to something like this with OCD. Is there a question? Oh, no, she's leaving. Okay. Oh, thank you. That was great. All right. That was wonderful. Okay. Yeah, opening doors for kids with contamination OCD, providing reassurance about performance, ordering for kids at restaurants. Yeah, allowing a kiddo to use gestures instead of talking. And again, if you have a child who's so shy that using gestures is still a little bit scary, let them use gestures and then praise them. That was awesome. You did it. Now maybe can we try a whisper? So I guess what I'm saying is all accommodations, I'm always looking at like, how can we level up? I'm always looking at where's the edge of your comfort zone and can we push you a little bit out a little bit further. So yeah, it's to limit accommodation is the goal as much as possible. Whoops. And then, yeah. So if you're sitting here thinking I thought accommodation was a good thing, it is. It is for many things, for people with learning differences, people, autistic people, people with ADHD. There are a lot of ways, people certainly with other kinds of like physical disabilities, things like that. But I hope it's clear why with anxiety it can sort of perpetuate and reinforce things. Okay, so the impact of accommodation. Accommodation really conflicts with the goals of cognitive behavioral therapy. And I'll get into a little bit more about what that is, but it conflicts with the goals of CBT in that we want to be building independence, confidence, new ideas about the world, sort of challenging those notions that the world is scary. And so accommodation prevents that. It kind of keeps kids, as Dawn said, it's like an enabling. It kind of keeps kids in those symptoms. It also prevents what we call habituation. So habituation is the same thing that happens when if you get into like a cold pool on a summer day, it's kind of cold, you get in and you're like, oh, I'm so chilly. And then you stay in for a while, you're moving around and you sort of acclimate to it, or that discomfort goes down. What we know from research is that with a lot of anxiety, with gradual and progressive exposure, that anxiety comes down over time. I'm somebody who I will tell you this as well. I guess I forgot a diagnosis, but I am somebody who was so socially anxious in high school that I would either, because I didn't know who to eat lunch with in the cafeteria, usually I was also kind of like a bad kid, I guess. So I would either walk home, skip the rest of school, or sometimes I would just like eat in the bathroom. Because I was like, well, but what if I go to a table and people reject me? So now I love public speaking. It's like my favorite thing. I just want to be, out and about. So thinking about that, I needed to experience that fear and take those social risks to be able to get to where I am now. Accommodation also limits opportunities for a kid to see that the feared consequence doesn't happen. If you're afraid of dogs, they're going to bite you. You'll never know whether or not they bite you if you don't go around them, right? It also reduces a child's motivation to change. Like, hey, if everybody else around me is accommodating me, I don't have to work on this. Like, this is pretty dope. I don't have to learn how to like advocate for myself. So not to say that most kids don't feel that way. They don't say like, well, this is great, but they don't have as much motivation. Let's see. It talks about independence, self-efficacy, and then also this has been shown across a lot of studies that higher levels of family accommodation are related to poorer treatment outcomes. So and that as well, regardless of how high the anxiety or OCD symptoms are, people tend to get better quicker when accommodation is removed. Because it's not like living, you know, it's not being reinforced at home. Okay, here's a little bit about reassurance seeking. So it could be a child asking a family member or a teacher repetitive and frequent questions, asking the same question over and over again. Now, again, this is, you'll see this as well with autism. I would say some of the differences here are that there's a real kind of, there's a real need for kind of like stability, routine, predictability with autism. And with OCD, it's often this kind of like this anxiety, you know, this like, I need to quell this sense of anxiety. Now, there's also a significant overlap between OCD and autism. So that can be kind of tricky if a kiddo has both, or anyone of any age has both, to try to figure out, okay, what is the amount of information that you need to be sort of certain in your routine and to feel like things are predictable? And what's the kind of extra, like you already kind of know, but you're just sort of scratching the OC itch. And I swear I could do a whole talk on that, on kind of autism versus OCD and when it happens together, because it is very, very tricky. So providing certainty in all situations. So reassurance, I guess that would be seeking certainty in all situations, not providing. But I have this really cool chart here about information seeking versus reassurance seeking. So sometimes therapists who I think, or parents or people who read about reassurance seeking as a compulsion sort of treat everything as compulsive reassurance seeking. And so I always like to say, like, no, questions are okay. If you ask a question once, and so this goes back to like is the picture straight? Like if you're asking it once, that's really different than like repeatedly asking it. Like I'm seeking the information, I get it, I'm done. Asking a question to be informed, versus asking a question to feel less anxious, accepting the answer versus like arguing, saying what if, insisting that it be repeated, asking people who are qualified to answer the question versus like asking an unqualified person. Was working with a 10-year-old with fears of getting sick and her throat hurt. And so she was walking around kind of asking people, sorry, I should back up and say this is when I was working in a partial hospitalization program. So there were a lot of like doctors, nurses around, and the kiddo was walking around asking, you know, the nurses, does it look like I have strep? Does it look like I have strep? And then we caught on like, okay, she's asked everybody. So finally she got to me. She was like, does it look like I have strep? And I was like, you know what? I think that might be your OCD. I'm not going to answer that. And so she goes home, and how a 10-year-old has access to social media, I don't know. But she posts a picture of her tonsils on social media and asks her friends, do I have strep throat? So I was like, girl, how many of them are MDs? And she's kind of like laughing. But it's like OCD just wants the answer, and sort of it doesn't matter if somebody's qualified, right?
Yeah, I think you've read my journal. Been there, done that. So not the social media part, but the repeatedly asking everybody and anyone possible, because the OCD will not be quieted.
Right. And there's like always a reason to be like, well, I'm not sure. And sometimes they are unanswerable questions, right? Like sometimes there's a form of OCD that's like existential OCD. So like needing to know for sure that like we have free will, or, you know, what exactly happens when we die. And so sometimes it's like OCD is demanding certainty and it just isn't there. Or sometimes there is certainty, but OCD doesn't believe it, right? So you can see either. So I really like this chart. Okay. So how do you reduce accommodation? So removing accommodation slowly, and while letting the kiddo know that the changes are coming. So this isn't something where kids wake up and it's like, I used to be a reassurance factory, but guess what? I'm done. It's like, you know, hey, we're going to try something different as collaboratively as possible, because, you know, I think that regardless of age, one of the most important things for me as a therapist is the notion of consent. And I want a kiddo's consent to like, hey, are you ready to do this thing? It's going to be hard. I'm here for you. And it is possible to demonstrate compassion while not accommodating. So I know you'd like me to check your homework again, but I'm not going to let your worries boss me around, you or me around like that. And this last part where it says the hierarchy, you can ignore that. That's kind of, if I'm talking to therapists, we make an exposure hierarchy. Okay, so let's say that a kiddo is asking repetitive questions. So you can give them an opportunity to ask the question themselves. So you can say to them, well, what do you think? Well, I guess I think that 10 other people said I don't have strep. So I guess maybe I don't. Okay. All right. Nice. Because a lot of times, and sometimes they'll just be like, I don't know. That's why I'm asking you, but it's worth a shot. Limiting the number of worry hours per question, worry questions per day, per hour, like one worry question per hour. That means like I'll answer one per hour. And then after that, we're going to have to wait, right? And it's teaching them to kind of like tolerate that uncertainty in the meantime. Inserting a predetermined length of time before answering. So like delaying it. And then I love this one. You can have rewards to increase motivation to tolerate anxiety. So like, let's say the kiddos get 5 coins in their pocket, and they can use those for reassurance. And the thing is, when you run out of those coins, you don't get any more reassurance. But if you have any coins left over, you can cash those in, and sort of like a token economy system. I did something similar. I was working with she was 5 at the time, a 5-year-old who she would get up in the middle, she would get out of her bed and come to the top of the stairs, and there was like a baby gate. She would yell down to her parents, are you okay? Are you okay? Are you okay? And they'd have to like say like, yep, we're fine. And then come back up and get her to sleep. And sometimes she would do that, you know, like 10, 12 times. So we put some Velcro on the baby gate, and then we put popsicle sticks, and she had, I don't know how many it was, let's say 5. She had like 5 popsicle sticks. And if she asked her parents, like, are you okay? Or anything like that, her parents would just come and like take one of the popsicle sticks, and they would tell her like, yep, we're okay. Remember, like, try to fight your worries. But then the popsicle sticks in the morning were sort of like cashed in for something, which was really cool for her. And it's a nice tangible way for kids who are younger. Let's see if there's any compliance issues. Perform a cost benefit analysis to increase insight. I wouldn't do this with kids necessarily, but with teens, you might say like, look, you know, I know it's going to feel better for you in the moment if I answer this, but think about how good you're going to feel if I don't answer this and you fight your OCD and your worries get less and less. So thinking about that long-term versus short-term gain. And then practice responding to reassurance questions in session. This is for therapists. So sometimes I'll role model, kind of like we'll role play some responses. Like, give me your most upset kid asking for reassurance. And then I'll kind of, you know, give them some strategies. Okay. I think I only have a few slides left. So this is going to be perfect with just a little bit of time for maybe one more question. But the good news is there's really good evidence-based treatment for OCD and anxiety. So cognitive behavioral therapy is kind of the umbrella term under which all the therapies that have the best evidence base for OCD and anxiety fall. So what is CBT? It involves helping kids to alter unhelpful thought patterns and implement new behaviors. ERP, or exposure and response prevention, is a treatment under the CBT umbrella. It's the number one, it's like the first line treatment for OCD. There are some other treatments like acceptance and commitment therapy that have some evidence, but ERP has sort of the biggest evidence base thus far. And mindfulness also has evidence as an adjunct to treatment. So in a nutshell, evidence-based treatment of OCD and anxiety for kiddos looks like kind of psychoeducation. So first, really giving kids a sense that like, hey, these scary thoughts that you have and these behaviors you're doing, this is pretty normal. Like, there are a lot of kids who have anxiety. Sometimes they'll say, you know, bring out some stats, or we'll kind of color something in that has, if it has, say, like, you know, 100 smiley faces on the page and they have OCD, we'll color in like 1 or 2 of them. If they have social anxiety, we'll color in more. It kind of depends. And then exposure methods. So this is, if we think about CBT, C is cognitive, B is behavioral. This is in the B category, behavioral exposure methods. So this can be imaginal exposures, means you're kind of like imagining a scary thing happening. We can use that, or we can do live exposures. And then from the cognitive side, or the C side, cognitive awareness and restructuring. So helping kids to notice, like, I noticed you have this thought that, you know, that's, I'm trying to think of what's an example of, oh, you have this thought that, you've had these things called panic attacks. And you're having a thought that, like, panic attacks, I get they're really uncomfortable, but you're having these thoughts about, like, everybody will laugh at me if I have a panic attack, or a panic attack means I'm having a heart attack. So it's really figuring out what are the thoughts and helping kids to kind of challenge those. And then somatic management skills training. So this could be kind of like self-monitoring your anxiety, rating your anxiety, things like muscle relaxation, diaphragmatic breathing, and imagery. What I will say is that studies have consistently shown, despite the fact that many times for me as a therapist, parents come in and they're like, can you give some breathing exercises or like relaxation? And I'm like, I can, but over and over again, studies have shown that oftentimes, unless people are trying to get from like a 10 to like a 6 in anxiety, it's not going to be the thing. Relaxation is not really going to necessarily be the biggest component. It's more about challenging yourself, getting out there, building that confidence. And then as a therapist, we look at relapse prevention, like, okay, what are some times when you might be vulnerable? How can we kind of build up your armor there? I won't get too much into this because I feel like we're getting in the weeds. But in terms of psychoeducation about anxiety, I want kids to know it's normal. Everyone experiences anxiety at times. Think about the person you think is the coolest person in the world. Well, I really like, you know, I look up to this athlete or what have you. Okay, do you think they've ever been scared? No. Oh, I bet you they have. Everybody has anxiety. And guess what? It's uncomfortable, but it's not dangerous. Talk also about how it's adaptive. Anxiety is helpful. If you didn't have any anxiety, you know, maybe you wouldn't be safe, right? Maybe you wouldn't be looking both ways before you cross the street. So I'll talk about the Yerkes-Dodson curve, which is this little guy. Again, if they're older, and sorry, I know there's only audio of this, so, but for those of you who can see it, meaning in the recording, basically we do our best performance when we're at sort of a moderate level of when I say arousal, I mean like emotional arousal. So like people who aren't at all worried about tests are actually going to do worse than people who are a little bit worried. So I like to show kids this, especially if kids are kind of like perfectionists. I'm like, look, you want to do well, but you're all the way up here on like high anxiety. You're physiologically up here. Let's get you to where like you can still be anxious. We're all anxious about things that are important to us. And again, anxiety is a problem when our bodies react to normal situations as if they were real dangers. So, you know, I'm over here and I've got this water bottle and it's like, well, is it dirty? Maybe, maybe not. But my mind is treating it as though somebody with, you know, somebody with norovirus just vomited into it, right? Like that's when it's maladaptive. And our goal is not to eliminate anxiety, but to learn to cope. Okay. Well, let me just, would it be helpful to just go through? Yeah, I think those are the last 3, or are there any questions? Because I don't know that we'll be able to get to questions.
I have a question, but I will hold it unless someone else has one.
Okay.
I will take that as no one has a question. I will ask a quick question, Dr. Mariaskin. How do you help children deal with once people in their lives know they have OCD, anxiety too, but for the purpose of this question, OCD, to be able to explain the difference between wanting a meeting to start on time is not my OCD. Liking a clean house is not my OCD. The anxiety that is produced because I didn't start at 6:30 and 10 seconds in, or that is a millimeter off. How do you help kids deal with that, where people in their lives, and I've had this, where your OCD is showing, that's your OCD, and I'm thinking, that's not my OCD.
And it's frustrating. Yeah, it is. I mean, I think communicating, yeah, I mean, even with regardless of age, it's about like, I think it's important to establish a culture of like trusting the person with OCD. Like they're the only one who can know, is this sort of a preference or is this OCD? And I guess an example that I have is, it's exactly what you said, which is, if something is a preference, oh, I prefer to have things clean, then, you know, there is flexibility around, all right, well, things got a little bit messy. I'd really like to take some time out to clean, but I'm not going to put everything else on hold and clean for 5 hours. And so that's how I've kind of explored it with people and empowered people to tell others about it, which is like, I mean, it's essentially what you said. I want to start on time. That's a value that I have. I can have a value. Now, a value can also be appropriated by OCD, and it can get really perfectionistic. But yeah, that's some of the language that I use. But I think everybody with OCD has had that. Where that misunderstanding of yeah. Yeah, because I'm pretty much I'm a high achieving person. I've ever since I was a bad student in high school, and then I got to college, and all of a sudden like the nerd part was activated, and I haven't looked back since. And so I do have very high standards for myself in terms of like, you know, being professional, and I always did in school, and that wasn't necessarily, my OCD didn't really attack that. It wasn't like, well, if I get a B, it's the end of the world. It was just like, oh, I'm really disappointed. That's important to me. All right. So with CBT, again, we're talking about challenging thoughts and changing behaviors. So let's see. That can, exposure therapy, or the behavioral part, is gradually moving toward, I think I talked about this, so compassionate, consensual, and creative. I love the creativity involved in my job. And then cognitive distortions, we want to challenge those. Those are things like all or nothing thinking, catastrophizing, which means not only could something go wrong, but I'm only thinking of the worst possible thing that could happen. And we can help kids gather evidence to refute these fears. And we can also help them tolerate uncertainty or the need to know for sure. Because again, sometimes our fears, we just can't know. And part of being alive and interacting with the world and having social connections and everything else, there is risk in it. And that's okay. Here's a sample exposure hierarchy that I might use as a clinician. So it might be for a kid with social anxiety, that making eye contact in the hallways, that's maybe they think it'll be like a 3 out of 10 on anxiety. And they've been avoiding it. So, okay, your homework is I really want you to make eye contact in the hallways, followed by saying hi to a peer in the hallway, answering a question in class, etc., all the way up to trying out for choir, right? So this is really cool because you can kind of do it in a stepwise fashion with a lot of reinforcement. And in concert with that, helping kids to kind of see, hey, are you using any of these really common unhelpful thinking styles? And we have some of the classics like all or nothing thinking or overgeneralizing, emotional reasoning, which is that assuming because we feel a certain way, it must be true. Well, I'm scared, so it must be dangerous. I'm embarrassed, so I must be doing something embarrassing, right? So these are just kind of the hallmarks, and this is very mildly scratching the surface of what therapy looks like. But I think a lot of these are things you can, you know, do even if you're not a therapist. So that is all I have. right on time. Let's see, I'm looking in the, oh, that was a direct message. I will respond to the direct message in the chat, but anything else?
I'm going to take that as no, and I'll take that as an opportunity to thank Dr. Amy Mariaskin for coming out tonight, taking time out of her busy schedule to talk about anxiety and OCD in youth. We appreciate this, Dr. Mariaskin. I want to let our members know who are here tonight, anyone who registers for one of our education sessions will receive the PowerPoint presentation that our presenters give. Dr. Mariaskin is going to forward it to me, and I will get it out to you as soon as possible, so you can follow along. So you can follow along with the YouTube audio that will be put up on our YouTube channel, which is NAMI D Info. That should be up sometime tomorrow. I will put a link to it in my Monday emails. I also want to thank you all for taking time out to come to our education sessions. I think this is very important for both NAMI and the community in general. We are always open to suggestions. This was something that I had wanted presented to our members, but we are open to suggestions. We'll be planning our next fiscal year's education session. So if there's anything mental health related or that you feel would help the people who are dealing with mental health issues, either as people with lived experience or caregivers or both, please feel free to email me at outreach@namidavidson.org. So all suggestions are welcome. Can't promise we can find presenters for everything, but we do our best to try to. We have a lot of community partners. We know people who know things. So are there any other questions for Dr. Mariaskin, or is there anything you'd like to share, Dr. Mariaskin, before we close out the evening?
No, not at all. Thanks for spending your evening here. And yeah, and like I said, you can, if I guess if you have any other questions or things like that, you can DM us on Instagram. I'm not the person that checks that, but they can get it to me. And I hope you have a great night.
Thank you. Thank you so much.
Again, thank you all for supporting our education sessions, and thank you again, Dr. Mariaskin, for this wonderful presentation tonight.
You're welcome.
Good night, everyone.
Bye.